Welcome everyone to today's Idaho Provider Immunization Education Pertussis webinar. If you are signed in live, thank you all for joining us. We do ask that you hold your questions until the end of your webinar, our webinar today, and please mute your phones if you haven't done so already. We'll then open up the microphones and chat messaging for those of you that have questions for our presenters after the presentations. This webinar is also being recorded so that it may be viewed at a later date. Today's presenters are Dr. Bożena Morawski and Dr. Christine Hahn. I will now introduce our first presenter, Dr. Bożena Morawski, who will be providing us with an Idaho pertussis trends update. Dr. Morawski received her doctorate in epidemiology from the University of Minnesota, and she has a master's degree in public health from the University of California in Los Angeles. She is an Epidemic Intelligence Service Officer with the Centers for Disease Control and Prevention, and she currently holds an assignment in Idaho. I will now hand this over to Dr. Morawski.
Thank you. Good afternoon, everyone. As Ms. L noted, I will be providing a brief primer on trends in pertussis incidence in Idaho from 2004 to 2018 this afternoon. This slide shows pertussis trends for the last 15 years in Idaho and nationally. Specifically, the number of cases per 100,000 population, or incidence rate, on the left axis, and the number of cases reported on the right-hand axis. The number of pertussis cases reported in Idaho from 2004 through the first part of 2018 is shown by the blue bars. Pertussis is typically cyclical, which you can see here with peaks in 2004 and 2014. The data for 2018 cover the period for January 1st through May 26th, but we can see that if trends continue, 2018 is positioned to be a peak year. The blue diagonal striping depicts projected number of cases that might occur from June through December should current 2018 pertussis trends continue. The red line depicts the incidence rate, cases per 100,000 population, of pertussis in Idaho. The 2018 incidence rate is shown as a dotted red line. As you can see, incidence rates are also cyclical, and 2018 is positioned to report the highest incidence rate in the past decade should trends continue. The dark blue line represents the U.S. incidence rate for the same time period. Idaho tends to be above or equal to the U.S. incidence rates. 2017 national trends match those in Idaho, but are not yet available for 2018. When evaluating these data, it is important to note that the surveillance definition for pertussis in an infant changed in 2014 to include a cough illness of any duration rather than requiring a cough illness of at least 2 weeks. This change might have resulted in more cases being counted among infants than in previous years. This graph shows incidence rates in Idaho by age category for the period of January 1st through May 26th for 2010 through 2018. Incidence was highest among infants below 1 year for nearly all years shown. This is particularly concerning given the potential for severe complications of pertussis in young children. Interestingly, for 2018, the rate of pertussis among 11 to 19-year-olds is much higher relative to other age groups than it has been historically. This slide shows the proportion of reported cases that were confirmed by laboratory testing, either by isolation of Bordetella pertussis from a clinical specimen or a positive PCR for pertussis. Thus far in 2018, the proportion of cases that are confirmed is nearly 85%, an improvement over prior years. We wanted to take this opportunity to remind providers about the importance of testing for pertussis, even if providers initiate therapy under a strong clinical suspicion of pertussis. Now that we have provided a statewide overview of pertussis in Idaho, I would like to present pertussis data by public health district. As many of you know, Idaho has 7 public health districts that are comprised of multiple counties each. All districts are shown here, and you can take a moment to identify your district if you don't already know it. This slide compares reported pertussis incidence rates within and across the 7 public health districts for January 1st through May 26th for the past 5 years, 2013 through 2017. There is potentially high variability within districts across years. Public Health District 3 provides a good example of this. Second, there can be large differences in pertussis rates across districts. So just because there are low rates of pertussis 1 year in a district does not mean that rates will remain low. Comparing districts across the year 2015 is a good example of this, where some districts were experiencing peaks and others had relatively low pertussis rates. So in the previous slide, we examined data from the prior 5 years, 2013 to 2017. This slide shows current year incidence rate data by district for the period of January 1st to May 26, 2018, with darker areas of red having higher rates of pertussis. Most pertussis activity thus far in 2018 has been in Southwest Idaho across districts 3, 4, and 5, which include the Treasure and Magic Valleys, followed by District 1. Many of the cases reported thus far in 2018 for Districts 3 and 4 have been associated with outbreaks extending beyond a single family. Central Public Health District, or District 4, did declare a community-wide pertussis outbreak in December 2017, which is ongoing. The date of symptom onset in the first outbreak associated case was September 5th, 2017. The current median age of cases associated with this outbreak is 14, with a minimum of 1 month and a maximum of 95 years among these cases. In Public Health District 3, Southwest Health District has declared 3 outbreaks in 2018. Symptom onset dates are November 23rd, 2017, February 14th, and March 18th for outbreaks 1 in blue, 2 in gray, and 3 in pink, respectively. The median age for outbreaks 1 and 2 are similar, 17 and 16 years, respectively, and the median age of outbreak 3 is a bit younger so far at 14 years. So that concludes the overview of our Idaho data, and I will turn it back over to Mizelle to introduce Dr. Hahn.
Thank you, Dr. Morawski. As a brief reminder for those of you with questions regarding her presentation, you will have an opportunity to ask those at the end of today's webinar. Now we'll move over to our next speaker, Dr. Christine Hahn. Just going to open up her presentation.
Okay, thank you, Mizelle.
And
I was going to, you introduced me. Okay, nice. I apologize. You go right ahead.
Dr. Hahn will be providing us with more information on pertussis and vaccine recommendations. Dr. Hahn attended medical school at Michigan State University. She completed a residency in internal medicine at the Mayo Clinic's Graduate School of Medicine and then completed a fellowship in infectious diseases at Duke University Medical Center. After a 2-year training as an epidemic intelligence service officer with the Centers for Disease Control and Prevention, she became the Idaho State epidemiologist in 1997, where she continues to serve in that capacity. She also serves as the medical director for the Idaho Division of Public Health. I'm just going to go ahead and mute everyone.
Yeah, we do hear a little background noise, so please remember to mute yourself if you can. If you're able to do that, we'll try to mute people as well from our end. Until question and answer time. Okay, well, I'm going to start talking while Mizelle's doing that. Are you all set? Yes. Okay, do we want to X that out?
Oh,
sorry. Okay. All right, well, I'm going to talk, so what Dr. Morawski gave you was a little overview of a brief overview, I should say, of some of the situation we're facing in Idaho now. And I hope the couple takeaways that you got from that is that we are seeing increasing numbers of cases in 2018. We are concerned about that. It's especially notable in the Treasure Valley and Southwest Idaho is where we've been seeing most of our increase this year, but that in any given year we do see outbreaks or increases around the state. So what are we going to do about it? Let me just quickly talk a little bit about that. Okay. All right, so I'm going to just back up a smidgy and just talk about why do we care about pertussis. Reminder to everybody, a couple slides just talking about the risks. So babies are the greatest risk for getting pertussis and also having serious complications. A high percent of them are hospitalized, and of those that are hospitalized, they can have some very, very severe illness, including pneumonia, seizures, apnea, and even death in some cases. And you can see from the chart here that the most of the deaths in the United States each year that are reported are in babies under 1 year old, as shown in the green color on your slide. As a reminder, though, adults can get it also, and this is a case study from the New England Journal of Medicine showing a 66-year-old female that had a rib fracture. And it is the elderly in particular that can often have severe pertussis due to just sometimes underlying health conditions and frailty. They have a harder time with pertussis. So it's this reminder that it's not just about the babies. It can affect adults severely as well, although it's less common. Pertussis can be also very contagious prior to treatment, and some studies have shown up to 80% of household members will get infected with pertussis. And it's especially true in the beginning before they're even diagnosed with pertussis. You'll see here from this couple visuals I have here that culture is recommended usually and is usually positive just in the first couple weeks of testing, but PCR, which is a better test in the sense that it is positive for longer, so we can pick up cases later in the clinical illness, is also another way to test for pertussis. Less ideal is serology. Sometimes if somebody shows up after 2 months of coughing, that's all the clinician has left. But usually we try to confirm with culture or PCR. And you can see there on the right that figure also from CDC showing that the period of communicability is also really in the early phase of illness, often when they're still just have that sneeze and cough. And by the time they've been coughing for several weeks, they are possibly by that point not even contagious or really treatable at that point. There's the recommendation is to not treat after about 3 weeks of illness because the bacteria is gone. It's just done damage, and the coughing is leftover damage to their airway. So cultures and all that on treatment become negative very quickly, and so that tells us that people who get appropriately treated can fairly quickly get back to school and work and all that, but without treatment they can spread the disease for quite a period of time. So does vaccination make an impact on that? You're thinking, well, gee, we vaccinated against this disease, so why is it going up? So just a couple reminders. Yes, it does absolutely have an impact, and you can see here, first of all, rates of pertussis, while increasing in recent years, are nowhere near where they used to be. You can see this from the CDC, this little graph showing on the left that rates back in the 40s, 50s, and 60s were much higher than now. We don't know that that was all due to immunization, which really began more routinely in the 1940s, but it is partly attributable probably to immunization benefits. We do know that unvaccinated children have a much higher risk of pertussis than fully vaccinated children. And we also know that when vaccinated children get pertussis, they tend to be less infectious, so you get fewer secondary cases, milder symptoms, and shorter illness duration, and they have fewer hospitalizations. Additionally, we know that vaccinating pregnant women is very effective in preventing pertussis in their newborns. We'll talk about that later, but that's an extremely important point for pertussis control. And we also know, an interesting study I'll show you next, that even just getting that first dose at 2 months has been shown to protect against death among babies. So even though the 2-month dose wouldn't be enough for durable immunity by any means, it does immediately start helping that baby out just getting that first dose. So this is a study I just alluded to. It's published in the journal Pediatrics, and they showed there that when they looked at many, many years of data. It was an incredible study, 1991 to 2008, and they showed that that just even having had that first dose was highly protective in preventing death, hospitalization, and pneumonia. So one thing that I threw the seatbelt slide in here because it's I think what the messages are similar, and I think this is an analogy that people find helpful. If you look at the data, I think most of us probably on the phone wear our seatbelts because we know they help save lives. But if you look at the data closely, this is from the National Highway Traffic Safety Administration, and you can see here that 48% of people killed were wearing a seatbelt, were not wearing a seatbelt, which means that, and so we know that that most people killed were actually wearing their seatbelt at the time. And I think because I think you'll hear people say, well, gee, my kid got their vaccination, or I heard Johnny down the street got vaccinated, and they still got pertussis, so it doesn't work. And to kind of frame it in a standpoint of risk reduction, that yes, absolutely, getting vaccinated against a disease, kind of like wearing your seatbelt, it reduces your risk. It doesn't eliminate your risk of getting a disease. What you hope is that you're less likely to have a severe outcome, such as death, and you're also hoping to, in the same way that you do when you wear your seatbelt. You know that it's not 100%, but you're playing the odds, hopefully in your favor. So I don't know if this analogy is helpful to you, but I find it helpful to think about it that way. So let's quickly go over the current recommendations for pertussis vaccination. In a nutshell, you're supposed to get 5 doses as a little kiddo, 4 pretty quickly in a row, and then 1 basically kind of pre-kindergarten, and then 1 dose as an adult, right, or adolescent or adult right now. So the vaccine, the Tdap, which is what we give to anybody over 6, anybody above the age of 6, we give them Tdap, is currently only licensed for one-time use. And that is why the recommendation reads the way it does right now. We'll talk about this a little bit more in a second. But basically, the way to remember it is 5 doses when they're little, and then at least 1 dose as an adult. And I say at least 1 dose, and we'll talk about that in a second. This is a visual that I like, too, because it's out of Ontario, Canada, so I had to tweak it a little bit for the U.S. recommendations, but think about it as 2, 4, 6 months of age to get that real primary series in there, get some protection while the babies are very young and very vulnerable. 1 more dose at 15 to 18 months, and then the pre-kindergarten shot about 4 to 6 years. Then, and I've got those in yellow to indicate that right now they should either get a dose as an adolescent or an adult. Most adults now never had an adolescent vaccine because it wasn't even available when they were adolescents. So there are a lot of adults out there that never got that adolescent shot. So there are probably a lot of adults out there that really still could stand to get a Tdap. So what about pregnant women? That's a whole different recommendation that you're hopefully aware of, that pregnant women should receive a dose of Tdap during every pregnancy, preferably at 27 to 36 weeks of gestation. The idea is to time it so that her immunity, the mom's immunity, reaction to that vaccine is maximum right at the time of delivery. So when the baby is born, it comes out just loaded up, if you will, with antibodies transferred from the mother. And while that baby is extremely vulnerable. And this is a very effective strategy to protect little babies, and they've shown that it is currently the most data I found said up to 93% effective in preventing these babies under 4 months from getting pertussis. If a pregnant woman didn't get it during pregnancy and has never gotten the Tdap before, it is recommended in the immediate postpartum period. Some of you guys might remember that was the recommendation for a while until some studies showed how safe it is during pregnancy. But now the recommendation is to get it during pregnancy. So you might ask, well, you just said that it was only licensed for one-time use. So the Advisory Committee for Immunization Practices doesn't do this very often, but they sometimes do recommend things off-label. And because of the crisis of increasing deaths in infants, they went off-label for this. And you can see here, this is, again, your recommendations for pertussis vaccines. And you can see here there are 2 off-label recommendations. The one that I'm just talking about right now is for pregnant women, 1 dose during each pregnancy. So that is indeed an off-label recommendation because it is multiple vaccinations in an individual. And the other off-label use for Tdap is in the 7 to 9-year-old age group. depending on which vaccine you're using. So for this kind of catch-up age group, for kids that you're vaccinating in this age group because they never got their childhood vaccines or didn't complete this early series, that is may also be off-label, and you want to check. Okay, so how are we doing with vaccinating the Idaho population? I'll just quickly remind you where we're at. For very young children, that early series that I talked to you about, we're doing okay. You can see here that the latest year that we have data on for 2016, we were right at the national average or even potentially slightly above. But basically think of us as we're doing okay, we're at the national average, not where we want to be. We'd like to be at about 90%, but really we have a pretty good immunization coverage in this very young age group. In teenagers, where we don't have 2016 data yet, but looking at the trend, we have been gradually doing better over the years. It's becoming more and more routine to vaccinate those incoming 7th graders. So our rates have been improving in that age group, but we're doing pretty well in that age group. Where do we really struggle is in adults. And this graph, which shows all sorts of vaccines in adults based on the National Health Interview Survey, you can see the two lines I've highlighted for you here are Tdap in age 19 to 64, excuse me. So these are adults who maybe the very young ones could have gotten it during their adolescence, or for more mature adults, they probably got it as an adult. And you can see that rate has been gradually going up, and as more and more people get this shot during adolescence, that number will keep increasing. But for people 65 and older, you can see it's lagging significantly lower than we are for younger adults, even though, as I mentioned, that they can have more severe complications from pertussis. So what about pregnant women and women who recently had children? I'll just show you two data points from our pregnancy risk assessment tracking system. So this is a survey that goes out to a randomly selected number of new mothers who have just delivered during a certain year. And from their latest data, what they show is that 84%, if you look over here on the left side of your screen, 84% of women who gave birth in 2016 said, yeah, I've gotten a Tdap before. It might have been before, during, or after their pregnancy, but they have at least received a Tdap. You can see that it looks like up in Panhandle or Health District 1, so this is the very northernmost part of our state. You can see it appears to be dipping a little bit lower, and it is indeed significantly lower than our statewide average. But most of the other health districts are about the same, of having a pretty good rate of having gotten a Tdap. However, if you look at the right side of your screen where the green bars are, this shows a percent of women that reported they got the Tdap during their pregnancy. And you can see here that this is based by your type of insurance they got. You can see here that women that had insurance through their work reported about a 60% vaccination rate. Women that got insurance elsewhere had a lower rate, but overall, and then you can see it here broken down by whether the mother was on Medicaid, TRICARE, or military types of insurance, other types of insurance, or not insured at all. And you can see here that it varies, but it is certainly not near the 90 or 100% we would like to aim for. And again, this is because this is the current recommendation that they would have gotten that vaccine during their pregnancy. So we have some ways to go, hopefully, with education and information. So what's going on here? I just told you, as you saw from the earlier slides, the pertussis rates are going up. Even though we've got now a cellular vaccine that was a switch made in the 1990s for safety concerns. We've got pretty good childhood rates. You saw the the adolescent immunization is increasing, so that's a good thing. And then lastly, even though that Tdap is darn low, it is going up slowly and surely, and the pregnant women we're making progress on with some pretty good rates there. So what's going on with this vaccine? This is a little bit of a complicated slide, so let me ask you, this is a really interesting report out of the New England Journal of Medicine, and there have been several other reports that have also had these findings. So let me just show you what this is saying. What this study looked at, there was a big outbreak in California in 2010, and what they showed was in the blue line, you can see that the pertussis rate in children by age, you can see here, was fairly low until about age 10 or so. It really shot up, was really high among 11 and 12-year-olds, 13-year-olds, but then it dropped back down at about age 14. And you can see there the rates were actually quite low during this pertussis outbreak. So what was going on? Well, one thing they looked at was they said, look, these younger children, they started using Tdap routinely at about, these were kids who are 14 years of age and younger, only got the DTaP, not the old DTP vaccine, the one that those of us who are older, the one that we got had whole cell pertussis in it. So is there something wrong with this new vaccine? Well, DTaP appeared to be protecting these younger kids, but what seems to be happening is that immunity wanes over time. And you can see in this next slide, so that's why these kids in this age group are particularly vulnerable. So here's another way of looking at that. What they were showing is that as kids, remember the kindergarten shot was about the last one they got. They're finishing up their series about this age, and you can see here that the percent of kids by age getting pertussis kept going up year by year by year. And if you looked at it another way, time since that last vaccine, you could see that after a year, after they finished their series, they already had more pertussis, and it went up and up and up. So these kids that are only getting the DTaP vaccine, their immunity seems to wear off fairly quickly. Even a year after they finish their series, they are already losing their immunity to pertussis. This is one other, I mentioned several studies have found the similar findings. This was an outbreak a little closer to us, at Washington State. And you can see here from an outbreak they had in 2012 that they looked at their cases. These are cases of disease by age group. And you can see we already talked about how little babies are the most vulnerable. Again, this was 2012, before a lot of pregnant women were getting vaccinated. And you can see the little babies had the highest rate, a very high rate of pertussis, and then it seemed to drop down. And these were kids that were getting their DTaPs. Their immunity has not worn off yet. They're still getting their series. And then you can see their rates going up, up, up. And what happens here is these are kids that now have hopefully just gotten their DTaP shot now that they're adolescents. Now I got to figure out how to go backwards. Oh, that actually worked. Okay, so you can see here that the Tdap here at their adolescent vaccine may have had an impact. So what's going on in these older kids? Again, these are the kids that probably had the whole cell vaccine or a mixture of maybe whole cell followed by some acellular vaccine. So they appear to have better duration of protection. That's the theory right now as to why we're not controlling this disease very well in young children. So conclusions were acellular pertussis vaccines do provide great short-term protection, but not long-term protection. So the question is, does this vaccine work? It's really like yes, but. It works well, but it doesn't last. And that is contributing to more susceptible people running around not immune to pertussis. Nevertheless, until we have a better solution, vaccination is protecting those who are vaccinated and is our best strategy for right now. So what are the long-term solutions? Just to kind of start wrapping up here. One thing is a new what everybody wants to see is a new vaccine that has more durable immunity. And we are not right now hearing of anything immediately on the horizon. There is research and work being done in this area, but what we've been told for the moment is don't hold your breath. That is not right around the corner. So even though that's what we would like to see, and hopefully we'll have one day as a much better pertussis vaccine, for right now we have to continue to assume that we're going to be dealing with an imperfect vaccine. The other thing that we can continue to work on is improve vaccination of pregnant women and adults. You saw the adult rate is the lowest by far, and a lot of work can be done in getting adults one-time Tdap to at least give them some short-term protection. Adults, because many of them got that whole cell pertussis vaccine as children, because when they were kids, that's what was out there, they may get a better boosting effect from that Tdap, and the hope is that they may actually get a more durable response to Tdap, even though that's an acellular vaccine. So it's not wasting your time to vaccinate them, that they might have good memory cells in there from their original childhood series, and they may do very well with one booster. That hasn't, I'm not sure if that's been proven yet, but that's the hope, and so it is worthwhile really talking with adults about getting that vaccine. Also, we continue to struggle. Pertussis is complicated in many ways. One of them is diagnosis and treatment. I talked a little bit about how when people are most contagious, this is a big frustration in public health and I'm sure in your offices, it is most frustrating that when they're most contagious is when they're probably not going to even come in. They don't feel that sick yet. And if they did come in, we wouldn't necessarily think pertussis. We start thinking pertussis usually only once they've been coughing for longer or if everybody in the household is coughing. So it's rare that we get to pick up a case early. So thinking about pertussis, especially when they tell you that everybody in the household is coughing because it's so darn contagious, that should be a big clue. But thinking about it earlier, diagnosing it earlier, and getting folks, including household contacts, and public health can help you with this. That's our job to help figure out who all might need to be prophylaxed. Sometimes we recommend antibiotics to children in a daycare or classmates in a school or things like that, and we can help figure out who all that should be. So we can do a better job with that. I also wanted to mention at this point, you can see there that adult vaccine quiz. I took it myself. I thought it was pretty slick. The CDC has on their website, and that can remind, that could be a tool used in offices to, while the patient's waiting to be seen, potentially, based on their age, their risk factors, et cetera, what adult immunizations they might be due for. Okay, so what can we do? We can continue to use our current tools as best as possible. Remember to check the registry. We have more and more adults in the Idaho registry, IRIS, and if you're not signed up for that yet, just Google Idaho's Immunization Reminder Information System and you'll find us. You can request to be added. And that's a quick way to check to see what patients are due for. That'll tell you not only what they've had, but also what they're due for. If they've already had DTaP, say, and they don't know which brand, you can also verify what brand they've used. Ideally, the recommendation is to use the same brand throughout the series, but if that's not available, to give them what you have, because it's most important that they do get vaccinated. Also, during outbreaks, and this is something that local public health struggles with when we start to see increases like we're seeing now, sometimes we even go so far as to recommend that babies get that first dose sooner, especially if the mother was not vaccinated during pregnancy, so the baby might be unprotected, we may recommend that the baby get vaccinated earlier. So that's something that public health will recommend and might send out through a health alert. Hopefully you guys are all getting our health alerts. If not, again, you can contact us and we will get you into the system or contact your local health district. Lastly, the Advisory Committee for Immunization Practices right now is probably not going to go so far as to recommend repeating Tdap every 10 years. This question comes up a lot. Well, I've had one Tdap. Now it's, in fact, I myself am in that exact same situation. I got Tdap for the first time when my son was born in 2006, and I am now overdue for my second shot because I'm sort of hesitating because I would really like to get another Tdap, and I keep instead of TD, but it's off-label. So when I go into my doctor this year, I'm going to ask. I will probably just request another Tdap. There's not thought to be any downside to that. It is just not officially recommended. So it's an off-label use of Tdap. So people like me that got that first Tdap and feel really good about it are now struggling with, do we go back to TD, which is the official recommendation. So you can see there that it's a little bit of a challenge right now. So TD is still the routine recommendation for that 10-year follow-up. Okay, a couple other quick tools. We were talking about pregnant women and vaccination. Obviously a difficult subject. There's a lovely New England Journal of Medicine review on maternal immunization, and if anybody wants to there's a place that people can email questions. If you want me to send you that article, I'm happy to do that. But remember that there are two that are routinely recommended for pregnant patients. It's flu shots and Tdap. Those are really the two. There's some other ones that can be potentially recommended, but those two are the ones that pregnant women should be recommended for. Remember also, I currently have a stepdaughter who is expecting. I actually emailed her this morning and said, I feel terrible not having asked you this sooner, but have you gotten your Tdap? Because she is now 33 weeks pregnant. And she said, yep, I just did. But it's a reminder, when you have a pregnant woman in your family, I absolutely will get will go talk to my doctor before the baby is born, because you want the family members. I don't live in her household, but I certainly want to go visit. And so please remember, family members, husbands, siblings, etc., are often the source of pertussis for newborn babies. Look at these two studies. One by Biscard et al. Showed that the mother, when you can find a source for the baby, the mother was the most common source, then followed by father, grandparent, siblings, etc. In this other study shown on the right, more recently published in 2015, they found that mother and sibling were the most common sources for babies. And what I thought was real interesting, I'm going to make this point on these two areas here. For mothers, it was significantly different. If the baby was 0 to 1 month of age, that's this light column, the mother was more commonly the source than if the baby was 2 to 11 months of age. And then we see a flipperoo, because a lot of times these babies may be going into daycare. In contrast, a baby who got pertussis that was 0 to 1 month of age rarely got it in daycare, probably because a lot of those babies aren't in daycare yet, but daycare was much more commonly a source for a little bit older babies. So don't forget, when a baby is going into daycare, it's a good time to ask. Some mothers have gone so far as to ask the daycare workers, are you guys up to date on your pertussis vaccines? Because you don't want your baby to get pertussis from a daycare worker. So don't forget, family members, we all need to be reminding ourselves to make sure we're up to date on our Tdaps or DTaPs if it's a sibling, younger sibling, or siblings under the age of 7. So a couple more resources before I finish for improving immunization rates in adults especially. I've mentioned the little quiz already, which I think is super cool, and there are some other resources for you. Remember that adults are our biggest gap right now, with only 2 in 10 are up to date. Again, part of that's because of the current recommendations. People like me who are at our 10-year or just beyond our 10-year window, what are we to do? It's certainly worth having a conversation with your patients about that. Okay, and thank you. I'm going to wrap up now, and it looks like we have a little time for questions before we end.
Thank you for speaking with us today, Dr. Hahn, and another thank you to Dr. Morawski. This concludes our pertussis webinar. We're now going to open up the webinar for questions over the phone and via messaging. I'm just going to make sure I unmute everyone here.
Does anybody have any questions?
And you can type them in also.
Okay, we have one question. And I'll just go ahead. And start with that one, and it is about why wouldn't ACIP recommend more frequent Tdap for adults? And it's a great question, because they already went off label with the pregnant women. Why not just do it for everybody? And I think this is a little bit of a struggle between so the manufacturer, to show that their vaccine is safe for repeated use. In theory, they should go out and look at safety studies that have shown that people have gotten it repeatedly. Now, you can see the manufacturer saying, but wait a minute, it's only every 10 years. How on earth are we going to do that for routine use? So it's a little bit of a standoff, I'd say, between the advisory committee wanting to stay on label as much as possible, wanting the manufacturers to do those studies before they recommend off-label, and yet, on the other hand, the urgent public health crisis that was being seen with the newborns. So I won't be surprised if they change their mind at some point, because I don't know that the manufacturers are gonna change.
All right, thanks, Dr. Hahn. Looks like we may have another question.
Yeah, we have a question about the Idaho Health Alert Network that I mentioned, which is how public health lets you guys know about any emergencies or things going on in your community. It might be an outbreak, it might be something else. And the best way to sign up for that is there's a couple ways. Like I mentioned, you can contact your local health district. We also have a website here that you can log on to and request access, which is basically health.dhw.idaho.gov, health.dhw.idaho.gov/IDHAN, so IDHAN. Again, contacting your local health district is a great way to do it as well, though. They all have health alert network systems, and we all work together. It's all the same system. Are there any questions on the phone? Those questions both came in by chat. Are there any other questions on the phone?
We've still got a few more minutes.
Got 2 minutes. Okay, I'm not hearing anything, so.
All right, I think that wraps it up. Thank you again to our presenters for taking the time out today to speak with us, and thank you for everyone for participating. A recording of this webinar will be posted later this summer for you to review at www.immunizeidaho.com. If you have some questions that you think of later, feel free to email the Idaho Immunization Program at iip@dhw.idaho.gov. And thank you again.